everyone. Thank you so much for joining us for today's Wait What conversation on racial disparities in maternal health. My name is Nicole Young, and I serve as a community investments manager for the Women's Fund of Western Massachusetts. I would like to thank everyone joining us today via Zoom, and also to everyone joining us via Facebook Live. The Women's Fund has been advancing gender equity for women and girls for almost 25 years. We provide community investments in the form of grants, capacity building workshops, hosting convenings around specific topics like this one, and uplifting women and girls serving organizations around strategic priorities, including economic security, addressing parity in positions of power and leadership, and freedom from gender-based violence, harm, and harassment. We want to take this opportunity to thank our underwriters at People's Bank for their continued support of women and girls in Western Massachusetts. Our Wait What platform allows us to convene members of our community to talk about emerging topics, bring awareness to pertinent issues that impact women and girls. April 11th through April 17th has been designated by Black Mamas Matter Alliance as Black Maternal Health Week, which coincides with Black Minority Health Month. We wanted to provide an opportunity to host a discussion on this topic, especially given what has been identified as issues within our own communities. Our 2019 Status of Women and Girls report reveals some pertinent facts about relevant disparities as they differ between counties and the services accessible to those within these towns and cities. According to our study, there are significant racial and ethnic disparities in receiving adequate prenatal care. They are linked to systemic injustices facing many individuals of color, including lower insurance rates, practitioners, stereotypes of women of color when providing care, and unequal education opportunities. And it is not just those lacking financial resources who are impacted by this. I encourage you all, if you have not done so, to do a quick Google search and type in Serena Williams' name and maternal health, and you'll learn about the situation that impacted her and her family. Today's conversation will feature 3 experts that are based in our region to talk about the pertinent issues and within these disparities. We are joined today by Tanya Santos, a certified nurse midwife at Baystate Health, Marissa Peasy, a community activist and Deputy Director of Programs for Civil Liberties and Public Policy, and Dr. Dana Campbell of the Women of Color Health Equity Collective. Please visit our website to read their bios. With a vast range of years of experience in serving in multiple capacities in our community, and actually across the country, Tanya, Marissa, and Dana have a lot to offer, especially those looking to advocate for themselves and their loved ones, and those who are looking to engage in systemic change. So I want to start the conversation with just getting to know the 3 of you, and then I'm going to turn it over to the 3 of you and then come back towards the end. But if each of you, starting with Tanya, can talk about your work, the work that you do, and then the work that your organizations do to address these issues.
Sure thing. Good morning, and thank you for inviting me to this important conversation. I'm really excited to be here, especially to be acknowledging Black Maternal Health Week. So my name is Tanya Santos. I'm a certified nurse midwife and practice at Baystate Medical Center, where I see patients throughout the healthcare spectrum, including during pregnancy, during labor and birth, and postpartum. I've been providing care in the Springfield area for about 18 years now, and am more recently spearheading Baystate Medical Center and the Department of OB-GYN's work around racial disparities and eliminating health inequities in the care that we give in our department.
I echo Tanya. Thank you so much for inviting me to be part of this really important conversation. I wear a lot of different hats in community. As Nicole spoke to, I am the Deputy Director of Programs at Civil Liberties and Public Policy. A lot of people in community also know us as CLIP. I am also the co-president-elect of the Abortion Rights Fund of Western Mass. I am also the co-organizer of the Doula Association for Reproductive Loss and Abortion. And finally, I am a co-facilitator and companion in the Empty Arms bereavement support programs. And so that's also where I'm really going to center my conversation with you all today around. So lots of different hats. I've been in the area since 2005. Have done reproductive justice work throughout that entire time in the Valley.
I can't wait till we get to the point where we say we're not muted. Okay. Good morning, everybody. I want to say, much like Nicole and Marissa, that I am both humbled and honored to be in this conversation today. As you mentioned, my name is Dana Campbell, and I am an assistant professor of public health at American International College here in Springfield. And in my other role, which I might add is a really big role, I am on the leadership team at the Women of Color Health Equity Collective. And you are probably familiar with our past name and work as Mother Woman. We consider ourselves a movement building nonprofit organization that's focused on community capacity to address the needs of BIPOC women and girls in the manner in which they should be addressed. And we do this through training and consultation, advocacy and partnering, and also research. I think we're going to talk about this a little bit more in detail later. So
yes, we will. So Tanya, if you want to start us off with the first question, and then I'm going to turn it over to the three of you and come back to facilitate Q&A towards the end.
Sure. So let's see, I think maybe I'll just take a few minutes to outline some of the racial disparities that we see in the obstetrics and the GYN world to frame our conversation, because that's a lot of why we're here. I'd just like to say that the racism that has set the stage the last several centuries for the disparities that we see today will take a long time to unpack and dismantle, but I have faith that we can and will do that. And my goal is to, in my work, is to make sure that we never find ourselves in this place again, where we are, reading about women of color and Black women dying in the media or having near miss experiences. Maternal morbidity, which means death, and mortality, which means severe sickness, is increasing in the US, which is in contrast to other countries that we tend to compare ourselves to. And Black women are 3 to 4 times more likely to die in the time during, after, and around pregnancy than their white non-Hispanic counterparts. And for every death, we know that there are around 70 instances of severe morbidity or near misses. So, maternal mortality is really just the tip of the iceberg, and underneath that is a lot of sickness and devastation for women and families. And we also know that death rates for infants are higher for Black women than they are for non-Hispanic white women. This is largely driven by preterm birth and low birth rate. We know that these disparities hold down to on the Massachusetts level. So it's not just national. We know that the situation for women in Springfield is worse than it is for women on the whole in Massachusetts. And we also know that these disparities exist outside of obstetrics. We can look to lots of areas of healthcare and find these disparities with hypertension and things like this. And in the gynecologic world, we see disparities in incidence and treatment and death from cervical cancer, breast cancer, guideline concordant care, or how likely are providers to follow the best recommendations when women have abnormal uterine bleeding, and moving into reproductive spaces like provision of contraception and management of ectopic pregnancies or pregnancies that are in the wrong location, and the provision of treatments that preserve future fertility versus those that do not. I think I will pause there and see if Marissa or Dana would like to add anything to that backdrop.
Sure. So I would love to just kind of contextualize what Tanya was just speaking to from a perspective of the community member that is bearing witness to these health statistics. because it's really important for us to ground in the actual lived experience of these moments, to feel the impact on our community. And because I feel like a lot of times people get caught up in hearing those stats and think about it as this national issue that's happening. It's happening all over the country. We know about it. Oh, how hard that is, when it's actually happening right here in our backyard, right here in our community. When we're walking into the hospital and we are meeting people at the moment of one of the hardest grief and loss moments of their life, right? Like the loss of this very wanted child. And when it's impacted by these statistics, it's almost a burden in addition to carry, because you have to, like, you're holding this, like, that you understand that this is something that is a system created moment for someone. And there's not much we can say about that part other than to explain it to them. So oftentimes I find myself in these rooms where I'm walking in and I'm meeting these families and I'm sitting with them. This is in the companion program that we run. So let me give a little background on the companion program really quick, because I realized that I'm talking as if everybody knows what we do. So what we do in the Empty Arms program is, in the companion program, is we go in the moments of active or immediately right after the loss of a child. And that can be from anywhere from 16, 18 weeks, all the way up to full term or post full term, like 42 weeks. And the range is just as wide as pregnancy range can be in experience, right? And when we go in, we are there to support the family. We are there to sit with them and help them begin to make some kind of meaning out of the experience that they're having in that moment. It's not like it's this automatic, like, oh, I know what to do. I've just experienced a loss, right? Like, a lot of people know you're going to feel hard, you're going to feel sad, but there's this unbelievable, like, melting of who we are as people and how to operate as a human. We just don't know how to move in the world. And I say we because I myself am somebody who experienced the support of Empty Arms through my own loss. And so we go in to just sit with people and meet them there, to support them, to help them begin to find their ground again. And so when we're going into this room and we're experiencing, bearing witness to the actual maternal statistics that Tanya just spoke to, it's heartbreaking on another whole level, because again, it's a system created thing. And so I want to just briefly speak to, like, the racism that created this moment, because when we were talking and preparing, it was really important to me that I said to the group that people understand that the racist system, the racist policies that play into the birthing process are similar to many other things that happen, right? We got here in these statistics because of the racist policies that have built up upon things such as midwives, right? Like Tanya's talking about being a midwife. The history of midwives in this country, and I highly recommend that people research this so that you can get more deeper the rabbit hole. Oh, hello, whose ever music that is. The history of midwifery in this country was that Black women were at the center of midwifery, right? We were the ones that were going throughout community and supporting birth. And as the medical industrial complex, and particularly white folk, started to clue into the amount of power, the amount of revere that we were receiving in community for being such a critical component, there was policies that started to be put into place, right? Like, so we couldn't bring certain we had to have, like, the medical bags that we brought, we couldn't bring certain materials and tools that we needed, right? Like, so all of these different ways that the system started to play into the way we could actively participate in supporting our community members reached a point to where Black women were displaced fully. The medical system came in and hospital births became the center of how we gave birth. And then you saw this re-entry of the Ina May Gaskins of the world, who saw the rebirth of midwifery. And all of a sudden, if most people, when they speak to midwifery history, they will land in Ina May Gaskin as the grandmother of midwifery. And I would like to argue and push us to go back and look at the historical notions of how Black midwives were the leaders in that work. And so when we look at that and we see that, and we see the impact of that, we see us being removed from the room and the medical system and the white system replacing us, we start to see how slowly all of these statistics are building up. In addition to some of the research that we know and we've learned about how racism is, as we've recently seen by the CDC, is a health issue, right? They have finally named it as a health problem that we need to take care of. And you can see when women have immigrated here, Black women have immigrated here, by one generation later, by the time they are giving birth to that first generation in this country, the women or the children that come from that generation are in the same health statistics that women who have been here for generations. So we see the impact of racism in just those two threads alone. So it's really important to hear that and understand that, so that when we're walking into the room, we're sitting with that family that is experiencing, which for me has been disproportionately walking into a room of Black and brown bodies. We now can see the ways that the system played that up. So I really want us to understand and begin to connect that is at the heart of how I believe we have gotten to these health statistics, and how my work is around beginning to displace that and beginning to take the burden from the parents and the families that are experiencing the most tragic loss that I have ever bared witness to a family or a person experiencing, and stop personalizing it and internalizing it as somehow this is something that we did, that we created, when in actuality, it's something that we're trying to survive. Mm-hmm. So I'll stop with that framing right now to move on to Dana, who's going to talk about the policy pieces, I believe, and then we'll get into a little bit more.
Yeah, well, I wanted to actually start with shared language, because I think that we have brought up some very important issues as it relates to race and racism. But I think it's, and as the root cause of some of the issues that Tanya mentioned. So I think it's important that we establish that. And so first, I think that we all believe that the root cause of the disparities that we are seeing stem from racism and not race. And so I want to provide definitions for both. First, race is a socio-political concept that is not rooted in biology. Okay, the phenotypical differences that we see have no hierarchical structure, and yet the social construct of race, which was created and used to justify social and economic oppression, has powerful implications, as we can see in maternal mortality and maternal health. But it has also been used to justify wars, enslave people, murder, genocide, etc. Okay. And along with that is the definition of racism. And I think, many of you who are on this call know or have heard many different definitions of racism, but I think it's really important that we offer a definition that includes the systemic nature of racism, rather than just a simplified version at the individual level, because this is bigger than, somebody calling me a name and somebody treating me in a particular way. Racism is a system of power and oppression that's codified into the laws and the policies and practices. And it's also embedded into the institutions that we operate under. And it's done so in ways that advantage the dominant group, which are white people, and disadvantages BIPOC communities, such as Black and brown communities.
Hey, Dana, can you define BIPOC for people on the call?
Oh, yes.
That term.
BIPOC, I could have used people of color. BIPOC is Black, Indigenous, and people of color. And the idea there is that we tease out the experiences of Black people in this country and Indigenous people in this country whose experiences with white supremacy are a little different than those who also identify as people of color. Any other definitions?
So yeah, I think if we try to look at the causes of these racial disparities, a lot of the traditional explanations that have been given are clearly not true when we look at the data. So, you know, poverty, this phenomenon transcends poverty, location, social determinants of health that we typically think of, like obesity, hypertension, smoking, all of the, and education. Education is actually one of the most interesting phenomenon, because I think it's an example of, one, how it is racism, not any of these other things, causing these disparities, but also a concrete demonstration of what we call weathering or allostatic load. So for women, Black women in this country who are college educated, they actually have worse outcomes when it comes to maternal morbidity and mortality and infant outcomes than white non-Hispanic women who have less than a high school education. So there is something about being in our institutions in our educational system that increases the wear and tear on the body. So racism is the cause of these disparities in my mind, in two main ways. One is by weathering and epigenetics. Weathering is the wear and tear on the body over time after sustained, repeated, stressful stimulus, like being exposed to racism. And related to that, epigenetics, which is the way that the body and the genes change in response to these stressful stimuli and get passed from generation to generation. Speaking to what Marissa was saying earlier about, you know, if we look at outcomes for Black and brown people who are new to this country, their outcomes are better than their daughters 2 or 3 generations later after they have been exposed to the racism in our country. And the second way that racism plays out and affects these disparities is by unconscious bias in the healthcare system and the ways in which we usually unintentionally treat people differently because of the color of their skin or other things about how they present to us.
So with you saying that, Tanya, it's got me thinking, you know, I've been sitting and like thinking about like what's really important for people in this call to kind of also get to situate and walk away with. And I'm thinking about the doulas and the support people who are also part of the community that's bearing witness to this, and thinking about myself and like I walk into the room and like navigating the medical industrial complex and being an advocate and really trying to hold like this advocate role while also being respectful of the systems that are in place to keep people safe and to make sure that, you know, all of those things. So how do we as advocates work better with the midwives, with the folk who are in the room with us, who also understand these disparities? And like, how do we begin to think about when we're walking into these rooms as an advocate and building these relationships? Does it begin with us coming together and convening and building? What are the things in the room that you're thinking of that we could do better as people in the room with this knowledge to begin to dismantle these statistics? I mean, obviously, when we're at loss, it's a little too late to try to dismantle for that one particular family. And what are the ways that we can start to work together, do you think?
Well, firstly, I don't think it's too late at that point, because there are still repairs that need to be made, and there is family that still has to continue on with this loss. So I think, you know, and by definition, even if we get maternity care at its optimum for everyone, there are going to be unfortunate outcomes. So we'll always be grappling with that and having to help people heal from really traumatic incidents, no matter how good we get. It's just a part of the human condition. That being said, you asked about how we can collaborate better, you know, in the room. So I think the first part of it is that it is on us as healthcare providers to set our minds straight and have a true understanding of the causes of racial disparities. So that's a lot of the work that I'm focused on at my institution, is making sure all of the people who work with women and families understand the causes, and that it's not poverty, it's not, gestational diabetes. These can potentially exacerbate or be contributing factors, but it's really difficult if we're not on the same page with you that it is racism, not race, if we're not in a place where we can be open and honest and compassionate with ourselves, that we all have implicit bias and need to check our implicit bias. If we don't believe it exists, then we can't find it and address it. So, I think that starting with clinicians who are appropriately trained and appropriately open to their role in bias is really essential. Once you have that, and once we all see ourselves as working on a team for the benefit of the patient, it shouldn't matter to me who says the thing, who says, can we stop for a minute and have another conversation about it? Or if you say to the patient, do you understand what Tanya said to you? Does that make sense? If not, let's ask to hear it again. Or, once we are part of a team, then it's all of our responsibility to make sure we're making decisions together in a way that's comfortable for everyone in the room. Does that answer your question?
Totally, totally. And the other piece I'm thinking about in that question is like this over dependency on dismissing people as experts on their own body, right? Like in my former work in the Prison Birth Project, another hat I wore, y'all, as a co-director of the Prison Birth Project, right? Like I heard that phrase over and over again behind the wall. The pregnant people behind the wall would consistently say, well, I would complain about something going on, something didn't feel right. I wanted to alert the midwife, I wanted to alert the medical staff, and I was told to drink water and lay on my side. And then I go out in community and I speak to families that are experiencing or have experienced loss, and the feedback is often, well, I complained to the doctor. I told them I'm having this issue. I told all the folks, the medical people, that this was going on, and they told me to drink water and go relax and put my feet up, right? Like a different version of it, but still the same kind of idea of, no, you don't know. We checked you 2 weeks ago. You're fine. Just sit with yourself. You're probably just being stressed out or anxious, or one of the other like throwaway words that takes all of someone's experience and feelings and dismisses them. And then unfortunately, often that's being told to me in the line of a story of loss, right? And now I'm sitting here in this experience, and I begged for this. I begged for somebody to check. I begged for somebody to do something. So I'm also thinking about that, like, what do we need to do? How do we, as a community, create more expertise in the body of the person experiencing the pregnancy?
Yeah. Marissa, I want to jump in
I
here.
totally.
Yeah, I think this is super important to understand that these biases that we have that may show up in attitudes, beliefs, but all in microaggressions, but also in our behaviors and the ways in which we provide services are learned behaviors. I mean, this is how we were socialized. We were socialized to think about people in particular ways. But because of that, because it was learned, we know that it can be unlearned. And where does that happen? I mean, it can happen, in various places, but it needs to happen. And particular for providers, it could potentially happen in medical schools, in the institutions that they are learning, where they are learning to be, midwives, physicians, nurses, etc. And then once it's learned, once the process is out there and it's learned, then people have to be held accountable for their knowledge that they have now, the knowledge and the skills that they have. And often that's not the case, right? Somebody, microaggresses and they get away with it. Somebody, a woman of color expresses what her body's experiencing and is dismissed, and there are no repercussions for that provider, for that woman. And so I think learning it and having people reflect on it and reflect on their socialization and the things that they need to undo, but also holding them accountable. And that I'm a huge believer in the holding people accountable, because I think one of the things that people of color or BIPOC people are experiencing right now, and we've always experienced it, but it has been heightened by COVID, is this, all of these things that are happening around us, and nobody is taking responsibility for them, right? It's almost as if the victim has to take responsibility for it. As a person of color, I'm not going to take responsibility for somebody shooting, one of my brothers. I should not have to. And so, I don't have complete answers, because I don't really know how this can happen, except that this is part of the work that we do at the collective, is really going to organizations and institutions and saying, hey, listen, you can say you want to be anti-racist or believe in equity, but saying that means absolutely nothing if you're not going to do anything, right? And so you need to be thinking about what it is your organization needs to do, what it is the people who work for you need to do, and then also be prepared that the consequences could be huge. You could lose employees. You could, be sued. All of these different things. But if that doesn't happen, we're not going to change anything.
Yeah. Yeah.
Yeah, I fully agree. So, at Bay State, we're working on this model of attacking racial disparities and health inequities clinically, systemically, and structurally, and also culturally. And, we're pretty good at the clinical pieces because we're first and foremost clinicians. We can, look at a clinical problem and say, oh, if we institute this checklist or this, this screening process, we think we'll see improvements. We can also pretty easily look at systems and say, oh, well, it takes people 20 minutes to get through to us on the phone. That's not going to work if someone's having an emergency. How do we troubleshoot that? Or, the structure of prenatal care is not working. How can we re-envision it, like group prenatal care? Or is there some sort of way to do hybrid in-person telehealth kind of stuff, although that has its own issues. But what's really hardest and most important is the cultural change. Because without that, no matter what other gains we make, we could be solving, one area of racial disparity when, as we're doing that, 5 others are cropping up behind it, because we're taking care of people with the same lens, with the same cultural backdrop. So a lot of my time is spent focused on figuring out how to change the culture of the care that we provide. And I think you're right. At some level, at times, it may come to people being leaving your team because they're not interested in addressing their bias. And working with a lot of providers, I think a lot about my message and how the message gets delivered, because there's a real mourning process that happens when you start to acknowledge your own unconscious bias and how it may be impacting the people that you take care of, and your role in the racist system that all of us are a part of. There's a real mourning process. And if we can't approach ourselves and our colleagues with humility and compassion, we're never going to change the culture. But to your point, Dana, I agree. What we permit, we promote. When we allow people to make disparaging comments about patients and frame patients as non-compliant, frame patients as not doing what we want them to do, we really do damage. And every time we let those comments slide by, we're empowering other people to continue with that mindset and make other comments like that.
Yeah, absolutely. You make this point. I wrote this in what I was going to say because I think it's kind of interesting. This whole notion of mourning, I like that. And for me, you know, what I would ask people to really consider is leaving the defensiveness out of this, right? Because if we can't go to somebody and quote, call them in or call them out on something that was done or said so that we can improve, then it's not going to work, right? And so I've been reflecting on Sharon Osbourne, which I'm sure many of you have heard about, you know, the hoopla with her, but really reflecting on how she went through what I'm going to call the classic defensive stages. It was almost like Kubler-Ross's stages of grief. You know, she got mad, she was yelling, she was crying, she, you know, asked, how can I be racist? And then she even requested that the victims educate her. And all of that with the response from Cheryl Underwood being very calm and collected and trying to engage with her really, you know, led me to think about how I am perceived as the angry Black woman if I am putting out the information, or if I am calling somebody in, or if I am advocating for myself as a, you know, as a patient. And some of you have heard of Robin DiAngelo, and if you haven't, I mean, I would look into, you know, as part of your work, but she said this thing that I thought really resonated with me. It was that she had asked an audience of people, what would it be like if people of color could actually provide feedback to white people and we receive it? And a Black man in the audience in one of her talks said it would be revolutionary. And that was like a slap in the face, like slap in my face. It was a much of a wake up call, because I think a lot of what we do is skirt around issues and not address the things that we need to address because of this. I don't know if it's necessarily a fear, that's probably not the right word, but like the repercussions of what will happen if we say to somebody, hey, your comment, your behavior is unacceptable, and here's why. And you were, Tanya, you were mentioning allostatic load and stress and all that. And I think we take that home when we don't say anything. We take it home and it builds up, and then it manifests into poor health. Or at least I believe that it manifests into poor health.
Among other things, right?
Among other things, yes. Absolutely.
Right, or it's just physical and mental health, right?
Right, absolutely.
So definitely the two that I think most. And also I just want to like name that like some of the other pieces that I often hear in this lane of like, you know, how to like think through and hold and hear the feedback. I'm also like interested to like sit with and hear how people go towards and find those markers in community that are doing the work, right? That are like really investing in the hard work of unpacking or decolonizing or interrogating, whichever word feels most comfortable to you, their racism and their internalized racism that every single one of us has to do, right? Like I have just as much internalized racism as the next person. It's the way that it lands in my body and the ways that the messages were received by me. And so like what's really interesting to me as I'm thinking about this and is like, I would argue empty arms is one of those markers in community that is doing the work, and we're not doing it perfectly, right? Like the other piece in that, what I was hearing in Dana's language is that there's this, the white supremacist cultural notion of perfection plays so deeply to the ways that we operate in the world, right? And so when this is all happening for people who are doing this mourning process of unlearning, and there's this expectation of perfection, right? And like when we sit in these conversations in empty arms and we talk about what it means to be a mostly white organization that is going in and working with these health disparities for Black and brown bodies, most of the folk don't know this lived experience, and yet we still have the messy conversations. We still hold ourselves accountable to doing the work that is required in order for us to show up in the room and understand all of that Tanya has lifted up for us today, right? Like there is no option for us, and for us, I'm meaning like the organization, but for my colleagues, there's no option for them to not hold that as part of the truth than when they're walking in the room. And so I would just guess I would say that part of where I think some of this health disparities continues to play out is that we're not talking to each other. We're not depending on each other. We're not learning from each other. We're not turning to the community, like people and organizations that are holding this work down, that are modeling for us what we need to do in order to go and begin to dismantle these statistics. Because like Tanya said, until people start understanding the impact of what they're supposed to carry and the understanding that they're supposed to have, it's going to be really hard for us to dismantle this. And so I'm imagining there's a lot of doulas and healthcare workers that are involved in this conversation today. And so I guess I would just, as we are about to move into question and answer, would throw out there that what I'm hearing in Tanya and Dana's language is that doing the work means really investing in doing the work and turning to those resources that are already doing it, that could be some kind of beacon of light towards the work that we all need to do as a community. Because this is not gonna, right, Tanya said, right, loss is gonna happen, reproductive loss happens. That is definitely a sad thing and not the issue that we're holding here. What we're holding is the disproportionate impact of reproductive loss on Black and brown bodies. Mm-hmm. So what are we as a community going to do to show up and change that? What are we as white members of the community, as people of color members of the community, what are we going to do as individuals to do our decolonizing and unlearning work so that we can show up in these spaces and also push for the policy changes that we need to see on the state level in order for our families and our community members to actually get what they need.
Right.
I was at a Zoom conversation about a film that's coming out, and I'm not going to remember the name, unfortunately, but it's a film being developed by two Black women. One is a doula and one is a midwife, and they're focusing on 4 women's experiences. And in one of them, the filmmaker who had a loss herself, and it's about Black women's experiences. One of the things that she does after the loss of her twins is they include in the film a conversation with the obstetrician who was involved, who is absolutely devastated, understandably, and heartbroken over this. The obstetrician is white identified. And one of the things she talked about in this session was how racism hurts everyone. We've all been dragged into this system that, we all have different levels of complicitness, is that a word? Complicity, or, actively fighting, or, there are people out there who are actively perpetuating racism and bias. But, even for those of us who are just trying to live our lives, not doing any harm, we are also being hurt by racism. So it's not enough to be race neutral or racism neutral. Unconscious bias is part of the human condition. And if we're not actively fighting it, if we're not actively working on it, then we're perpetuating it.
Perfect. And I think that's a great segue to go into our Q&A. So I wanted to begin the Q&A discussion with a question around, for those of us seeking care, how do we best advocate for ourselves?
Is that to anyone in particular?
You want to take that, Marissa?
Sure, I guess I will. Advocacy in these moments is like probably the hardest piece that we often bear witness to and hold. So when we go into a room and we are experiencing the family in whatever moment they are in their loss, the first thing within, well, not the first thing, but the first thing is love and hugs and where are you at and what do you need in this moment. But somewhere in that conversation is the reminder of agency, because that's usually one of the first things that goes in trauma, right? Like we lose our agency pretty quickly when trauma is happening. And so advocacy in these moments is like saying, I don't even know, I'm not going to try to create some kind of metaphor, though I love to speak in metaphors, let's be real, y'all. But like advocacy in that moment is almost impossible until you're reminded of it and or can remember it. And so I think that it's not so much about you as the individual needing to hold so much agency in that moment. It's you remembering that this is going to be one of the hardest things I've probably experienced. Let me bring a support person with me that can help me advocate. I know when I was going through my own loss, I couldn't even hear what the doctors were saying at me. And that's what it felt like. They were talking at me because I did not feel part of the conversation. I did not feel part of anything that was going on in the room. I was shutting down. I was moving into shock. I was overwhelmed by everything, the lights, all of the things, right? Like the room was just too much. And so what I had was a doula in the room, right? I had a doula that was there and she would be like, okay, so this is what they just said to you 15 minutes ago. And we would reprocess all of that information over again so that I could actually sit in it and slowly consume it because it was so shocking and overwhelming. And so the best way to actually advocate for yourself when you're in a really hard space is to trust that that is not the moment where your agency is going to be able to shine the brightest. And so having somebody there that can support you and can support you in your wishes and can keep you on centered in what you want with your own body is the most critical and important way I think we can self-advocate, is to bring a support person, because it's just too much. It's too much to ask the person who is experiencing the trauma to somehow figure out how to navigate that situation, right? And that's also where I think, particularly for Black and Brown women, that's where Superwoman complex comes in, where we're expected to always be the person that can do it all and we can take it all and this is going to hurt us, but we can rebound, right? I also want to throw in there, recently I was talking with another woman of color who was like, I think we need to challenge this word resilience, particularly for women of color, because resilience is somehow like this, like, oh, we overcame that really awful, horrible thing. Because I personally consider myself a survivor of one of the most traumatic experiences of my life. And I am a survivor that has figured out how to move forward. I am not a resilient person from that experience. I don't feel like anything was beneficial about that experience. Like, so to sit in this idea that resilience to me is further teasing out this idea that we're self-advocates, that we're perfect, that we're strong, that we're all of these things. And so I would argue that the strength is actually in the support. The strength is actually in allowing yourself to be in the moment, be present in the moment enough to just let whatever is going on in your body happen, and know that you have somebody in the room who will steer you in the direction that you need to go in because they know what you want and they have your needs centered.
Thank you so much, Marissa. I'm going to move on to the next question because we have some really great questions that came through both in the chat and on Facebook. The next question is regarding policy or legislative changes. What policy or legislative changes would you make to address these issues? I know there could be tons of suggestions, but what are some of the most pressing?
That's a good question. So, I'm a believer that you put equity in all policies, right? And I don't think that that is the lens in which any of our policies, particularly in the state or the more local level, are being prepared or changed. And so I can't say that there's necessarily one thing that is pressing, but if we take a look at all of our policies and really look at them from a racial equitable lens, we might actually see where we are doing more harm than good with many of our policies. I mean, I even think about the COVID-19 vaccination policies and people's access to vaccines, not just in this state, but across the country and even across the world. Those policies, which were not really based in anything, could be seen as very inequitable and racist in some regards. So, there are things that are, of a special importance to families, like childcare for all and, one payer systems and, universal healthcare. I mean, there's just a lot of different things like that. But I think if we look at all of our policies from a racial equity lens, I think we would benefit. Everybody would benefit.
And I want to throw in there, oh, sorry, you go first, Tanya.
Oh,
You go
I
first,
think
Tanya.
if we start tying healthcare reimbursement to patient satisfaction more, then healthcare systems will get the message real quick.
I love that idea. And I just want to really quickly throw in, there are policies already in the process, in the works in this state, that it's really important. If you don't know, I would strongly encourage you to search the State House bills and all of the different bills that have just recently been filed, right? The filing date, I believe, just recently passed. And so I know there's a doula bill, for example, right? Like doulas, there's empirical research that proves that doulas change the outcomes in the room, right? So there's a doula bill in this state right now that died in the last session that didn't make it through. But if this bill passes, that means the doulas would be reimbursed for their work. That means that there could be more doulas in the room because we have more people getting paid for the work that they should be getting paid for already anyway. So that's just one example of policy. Another example is we just recently passed the Roe provisions. There was the Roe Act in this state that was trying to be passed, and we got it passed, y'all, through a budgetary movement, right? And so now in this state, you can get a termination, which we didn't even talk about that lens of the story that I work in with Empty Arms, but you can terminate your pregnancy if you have a diagnosis that is incompatible with life after 24 weeks now, right? Like you now have a lot more agency about the way that you get to make the decisions about your body and about the life that you're carrying within your body. There's so other bills that are existing and moving. There's a maternal health commission that was recently passed that's in process of being formed. There are so many bills out there that it looks like somebody in the chat is putting it in. So I would really encourage you to look at the State House, figure out who's filed these bills, and start organizing around it. There's so much opportunity for us as community to continue to organize.
Perfect, thank you. There's two more questions that came through. So we have, actually what I'm gonna do is combine these two because I think they're very similar. So considering the structural racism that is embedded in the US healthcare system, what are the first steps healthcare workers, providers, staff, and administration can take towards creating equity in OBGYN care? And then what advice do you have for white healthcare providers and birth workers regarding counseling BIPOC folks about risk during pregnancy, birth, while acknowledging the role of racism? So they're related, but it's two-pronged. It's first addressing the structural racism, and then also advice for white healthcare providers.
So how about I take the advice for white healthcare providers, and then maybe Dana, you can speak to some of the structural racism stuff. So for white identified healthcare providers, I would recommend you do the implicit association tests. If you haven't already, there are lots of them. You can find them online. They're a really great way to explore your biases in the privacy of your home or your office. In particular, talking about counseling. So, a lot of the language that we use in healthcare blames Black and brown bodies for the thing, for the hypertension, for the diabetes, for the increased rates of this or that. So I've been doing a lot of thinking about reframing that and blaming racism, not race. And how do we have those conversations with patients? So I think that we have them awkwardly and imperfectly, as Marissa said, but as honestly as we can. So when patients come to me, that conversation tends to be a little easier if they start it. But, I think one good place to start is there anything you're concerned about or afraid of? Because women have heard this, they know this, it's all over the media. So if they're not talking with us about their fears, it's likely because they think that they shouldn't or that they can't. So I think just opening the door to what's on women's minds and what they're worried about will probably open up that conversation in a natural way. Beyond that, I do counsel women that it is racism, not race, that causes these disparities. I talk about the ways that our institution is working to combat them, and I talk about things that they can do personally to combat them. Marissa talked about advocates. So if it's a low risk situation, you're going in for a pap smear, you may be able to advocate for yourself pretty easily in that situation. But when things get scary or higher stakes like labor and delivery, people become less and less able to do that. So doulas, a family member, a birth plan, those are all things that can help you advocate for yourself when you can't do it verbally and in real time. And so encouraging patients to use those tools. And then I tell patients, if you don't feel heard, use those words. I don't think you're hearing me. You're not listening to me. That should be a trigger to any healthcare provider that you need to take a minute, slow down, and make sure you and your patient and family are on the same page.
Okay. So in terms of structural racism or what organizations can do, we at the collective we use a perspective called cultural humility, which was started by Drs. Melanie Turvalon and Jan Marie Garcia on the West Coast. And it's been around for quite some time, and it was in response to Rodney King, ironically, which happened 30 years ago. And we know that things have not changed in those 30 years in terms of police brutality. But it is one tool and that we use. There are other tools in racial justice work. It focuses on the self, and I say like what you bring to the table. It focuses on building and sustaining meaningful and mutually beneficial relationships that includes power and privilege, or how you bring what you bring to the table. And then also holding organizations and institutions accountable to the work. So we believe strongly that at the community capacity level, cultural humility and this work is really important. I mean, it's very important at the individual level, but most of us work in institutions that create these barriers or parameters in which we work in that don't allow us to really do the work that we want to do. So we do trainings in this, and we also have been doing consultations with organizations to provide what they need to move their organization into a more an organization that's more focused on equity, or whatever they want, whether it's anti-racism, cultural humility, whatever it is. And so those consultation services usually come with conversations about how the organization is operating, where they are in terms of this kind of work. We do assessments both at the organizational level and at the individual level. We do trainings, and then we help the organization to begin to incorporate equity into their strategic plans and for themselves as well as their employees. And again, as I mentioned earlier, we talk a lot about accountability, both at the individual level, but also at the institutional level. It's really important for the institutions to take on accountability. When they don't, then these things they make no, they're just words, right? They're words that are thrown out. They're the statements that people put out after George Floyd's murder, with no meaning, no backdrop, no anything. So that is part of our consultation with organizations. What we're hoping is that particularly for Western Mass, because that's where we live, that we can move that conversation through Western Mass. Also advocate and partner with organizations that are wanting to change local and state policies. With all of that, I think that we can make some huge changes towards health equity and racial equity in our state, at least.
Also acknowledge that the racism of the other institutions that are impacting these folks' lives, right? Like the racism of housing, the racism of food systems, the racism of school, right? It's not just the racism in the medical industrial complex. It's the complexity of the amount of racism impacting their lives in all of the facets, all of the lanes of their lives that impact the way that they are currently in front of you experiencing these maternal health statistics. So I think that's also to be held, so that it doesn't again turn into what Tanya was saying, some blame game of you must have done something wrong, when in actuality you're just trying to navigate racism in every facet of your life.
I want to thank you all for joining us today for the conversation on racial disparities in maternal health. Thank you to those joining us via Zoom and Facebook Live. I especially want to give a special thank you to our panelists, Dana, Tanya, and Marissa, for joining us today and for lending your knowledge.